Good morning, students. I am Ms. Republica Borgohain, Assistant Professor, Assam Downtown University, Guwahati, Department of Pharmaceutical Science. So today I will be discussing about the inborn diseases in my previous video which I have discussed, and now I will be going to discuss about cystinuria. So it's a defect in tubular reabsorption of cystine. Urinary excretion of cystine is increased in this case. Being sparingly soluble, cystine deposits in the kidneys and forms cystine stones. The defect also involves reabsorption of lysine, arginine and ornithine. In the homocystinuria, it is a cystathionin synthetase is severely deficient in homocystinuria. So in case of homocystinuria, in this disorder, cystathionin synthetase, it is severely deficient. That means in the absence of this particular enzyme, homocystinuria occurs. This impairs the conversion of methionine into cystine. Homocysteine accumulates and is converted into homocysteine. Homocysteine is made up of two homocysteine molecules. Urinary excretion of homocysteine is increased. Plasma methionine and homocysteine levels are increased. The clinical features of homocystinuria are thrombotic phenomena, osteoporosis, dislocation of lenses in the eyes, mental retardation, ischemic vascular disease. So these are the clinical features of homocystinuria which are caused due to the absence of this enzyme. So accumulation of homocysteine causes abnormal cross-linking of collagen, abnormalities in the ground substance of walls of blood cells or blood vessels, then increased platelet adhesiveness. Dislocation of ocular lenses and osteoporosis occur due to abnormal collagen. Thrombotic phenomena occur because of abnormalities in the walls of blood vessels. Then increased platelet adhesiveness and abnormal vessel walls cause ischemic heart disease, cerebral thrombosis and peripheral vascular disease. So ischemic vascular diseases occur at a very young stage. Homocysteine has been described as the new cholesterol because of its propensity to cause ischemic vascular diseases. Early diagnosis and treatment prevent most of the clinical abnormalities. The treatment consists of a low methionine, high cystine diet. Iridoxine supplements may be given to activate the residual cystathionin synthetase. Hyperhomocysteinemia may occur due to deficiency of some vitamins also, especially folic acid and vitamin B12. In such cases, vitamin supplements correct the abnormality. Here we can say that the hyperhomocysteinemia may occur due to some deficiency of vitamins, especially folic acid and vitamin B12. So, if the vitamin supplements which are deficient causing this disease are intake timely, then the abnormality may be corrected. So now comes the phenylketonuria, that is PKU. Phenylketonuria is the commonest inborn error of amino acid metabolism. So it is an incidence of about 1 in 10,000 live births. So in 10,000 live births, out of 10,000, only one may be affected by phenylketonuria. So it was the first inborn error of amino acid metabolism to be treated successfully by diet manipulation. So there is a block in the conversion of phenylalanine in the tyrosine in phenylketonuria. 2/3 of the patients suffer from phenylketonuria, that is type 1, and phenylalanine hydroxylase is deficient in type 1 phenylketonuria. Several mutations have been observed in the phenylalanine hydroxylase gene. 1/3 of the cases are due to a defect in dihydropteridine reductase or conversion of GTP into tetrahydrobiopterin. So 1/3 of the cases it may be due to the defect in dihydropteridine reductase enzyme or conversion of GTP into tetrahydrobiopterin. So this is the structural elucidation which occurs while the diseases or the enzymes when they react with the particular amino acid. So the degree of defect is variable, but it is severe in majority of the patients. So plasma phenylalanine concentration rises after ingestion of phenylalanine. When the level exceeds 1 millimole per liter, alternate metabolites of phenylalanine are formed. The alternate metabolites include phenylpyruvate, phenyllactate, phenylacetate, and phenylacetylglutamine. So these are the structures. These are the alternate metabolites of phenylalanine. They are a structural elucidation. And now we are going to discuss that the plasma concentration of phenylalanine, it is being raised in case of phenylketonuria. Plasma concentration of its alternate metabolites, it is also raised. And all these are excreted through urine. Some other amino acids, they share their transport system with phenylalanine. A high phenylalanine level may inhibit their intestinal absorption and renal tubular reabsorption. Uptake of these amino acids by brain may also be inhibited. Synthesis of myelin sheath is decreased. Synthesis of norepinephrine in brain is decreased. Then decreased availability of tyrosine may decrease the synthesis of melanin. So clinical manifestations appear a few days or weeks after birth. So development milestones are delayed. Then motor hyperactivity and seizures occur. Skin is hypopigmented. Later on, there is severe mental retardation. Early diagnosis, that is within 3 weeks of birth, and treatment prevent the clinical abnormalities. Since phenylalanine is an essential amino acid, it cannot be excluded from the diet. A low phenylalanine diet is given to keep the plasma phenylalanine level below 6 mg per deciliter. Tyrosine cannot be synthesized endogenously in phenylketonuria. Hence, tyrosine becomes an essential amino acid for patients with phenylketonuria, and their diets need tyrosine supplements. So, dihydropterin reductase is deficient in phenylketonuria, that is type 2. There is a block in the synthesis of tetrahydrobiopterin from GTP in phenylketonuria, that is type 3. This too also results in decreased conversion of phenylalanine into tyrosine. Then tetrahydrobiopterin is also required for hydroxylation of tyrosine and tryptophan. So deficiency of tetrahydrobiopterin results in decreased synthesis of dopamine, norepinephrine, and epinephrine from tyrosine, serotonin and melatonin from tryptophan. And the clinical abnormalities in phenylketonuria for type 2 and type 3 are, they are more severe in nature, they appear early, they do not improve despite diet manipulation. So in my next video, I will be going to discuss about Alkaptonuria. So this was the disorders this much. Thank you.